Hi everyone, my name is Paula Sanchez-Hernandez, and this is my ERSCO presentation on examining protective culture values in the uptake of a community health worker setting for Latinx populations. My co-author for this project was Bianca Avila. There are various cultural considerations to keep in mind when treating Latinx populations. Among them include familialism, so how closely one feels to their family unit, confianza or trust, how much trust is reported between the client and the provider, as well as stigma. Latinx populations tend to report high levels of mistrust in communication in healthcare settings, and this may explain how we can improve delivery in the future. Among usages of mental health services, Hispanic and Latinx populations are on the lower end of utilization. Various barriers contribute to this number, including various forms of discrimination, as well as acculturation and immigration. Additionally, we see a high prevalence of mental illness in Latinx populations in the US. So what are community health workers? CHWs are individuals who are trained by those who are licensed to provide care to those in need in their communities. They are trained with CBT and mindfulness components, and they're cost-effective and community-based, meaning that there's little to no cost involved. And there is also the use of task shifting, which involves redistributing responsibilities to make sure that those who are in need the most also receive the care that they need. We also see the importance of a cultural ethnic match, meaning that someone having a CHW with the same cultural and ethnic background as them can improve cultural sensitivity, which can increase participation in mental health services. So my research question is, how are culturally sensitive factors incorporated and received by Latinx populations in a mental health setting? Specifically, how did participants view CHW addressing issues related to culture to better understand the processes of an ethnic culture match, which can enhance culturally congruent mental health care? This better informs future CHW mental health delivered interventions. For methods, what we did was construct semi-structured qualitative interviews, which are conducted over the phone with participants from an existing study. Most of these interviews were in Spanish, ranging from 10 to 20 minutes, and all of my participants, which are 7, were female, and the median age was 41.29, and thematic context analysis was used to analyze the data. Some sample questions include, did your CHW develop trust with you? Did you feel a sense of connection with your CHW? Did your CHW address issues about needing to balance obligations to your family, ways to support your family, or your values around family? For analysis, what we did was transcribe each audio into a Word doc, and I familiarized myself with the material through the process of memoing. We began open coding and met weekly to discuss the themes that we found, and these themes were used to create a code book using larger constructs. We coded the materials, and afterwards, a code summary was created for each code. For confianza, what we found is participants highly endorsing this, saying you start to gain trust, talking, and not with your family, but with other people, where you might be open with that person, then not with a family member, where you might feel that they might take that you're crazy. I feel that it is something serious. CHWs treat things seriously. They won't go and tell others what you're talking about, and I feel that that's why I feel a sense of trust. Similarly, another participant saying, when it was time to be open and trust one another. And I told him things that can be hard to share with at first when you're talking to someone and you don't know who you're talking to on the other end. There was already that trust. I opened up. I could tell him that, no, I'm not from this place and this happens to me. I feel bad because of this and I have these problems. For familialism, participants were able to bring their family concerns into the intervention, saying, I felt like my CHW had a way of talking to because I have a child with autism. I'm always worried about him and for the future. I would comment about what worried me about it, and she listened. And I felt that she took out all this that I sometimes have, and that's what makes me depressed, thinking about my son's future. For stigma, individuals were able to identify how mental health treatment raises awareness around certain topics and conversations. More participants saying it can help people make culture because sometimes in our culture, one keeps their feelings to themselves. One sometimes shows themselves off because they have things that they don't want to talk about. Another participant saying, many people often say, I can go see a shrink or a specialist, and I say no. They ask you questions that can make you vent, and it's good sometimes to know that someone is there for you. Overall, what we saw was a strong working relationship between the client and CHW. Participants indicated that they highly valued the incorporation of familial values while addressing their issues and concerns in treatment. Boundaries for communication and confidentiality allow for trust to be developed. Additionally, the importance of an ethnic and linguistic match, so having the same ethnic background as your CHW, allow for open conversations related to shame and embarrassment in mental health, as well as the negative effects of conforming to these values and expectations in the community. And it allows us to see what components may play a necessary role when delivering care in culturally sensitive manner for this population. I would like to thank my faculty mentor, Dr. Gabby Stein, Pooja Patel, who played a key role in this project, as well as members of the Caminos Lab and the Strong Minds team, and my co-author, Bianca Avila. Thank you so much for your time.